Bowel elimination. All of these structures are necessary for the defecation process. Normal defecation begins in the left colon, or the descending colon, with the movement of stools towards the anus. Clients that have cardiovascular disease and glaucoma, increased intracranial pressure, surgical wounds, and elevated blood pressure absolutely have to avoid straining. Straining can cause heart dysrhythmias. You need to be familiar how all of these factors can affect bowel elimination. Developmental changes can affect elimination. For example, infants have small stomach capacity. As people age, the GI tract will naturally slow down due to changes in circulation, muscles, peristalsis, and eating habits. Diet and fluid intake alter elimination. The body needs fiber to provide bulk for fecal matter. The body also needs grains, fruits, and vegetables. Chapter 44, Nutrition, helps outline how all of these foods are necessary to help digest food. Can't even think of what I'm trying to say here. The body also needs an adequate fluid intake to liquefy intestinal contents. Physical activity helps promote peristalsis. Prolonged emotional stress can impair all body systems. Stress can be a causative factor for things like colitis or ulcers or Crohn's disease. Personal habits. Many people prefer their own bathroom facilities and want to use this facility when at all possible. Chronically ill and hospital clients don't always have privacy, and that can affect the defecation process. Injury or disease. Musculoskeletal injury, cervical injury, MS, ALS, Parkinson's disease, or myasthenia gravis, all of those can affect defecation. The position the client is in. We know that squatting and sitting is the normal position, but if they're not able to do that. Pregnancy. As pregnancy advances, the size of the fetus can put pressure on the rectum, and that can cause an obstruction or constipation. Surgery and anesthesia cause a cessation of the GI tract function, and it can last up to 48 hours. If the client cannot eat after surgery and remains immobile, a paralytic ileus can develop. Improper use of laxative and cathartics cause the intestines to lose muscle tone and become less responsive to medication stimulation. Diagnostic exams such as endoscopies or colonoscopies can require bowel prep. Before and after the procedure, the client can experience gas and loose stools until a normal eating pattern is resumed. And incontinence or leaking of stool. These are common bowel problems, and again, you need to be familiar with each one of these types of issues. Certain diseases can cause conditions that prevent normal passage of feces through the rectum. These procedures have both physiological and psychological consequences. You may have a temporary or permanent artificial opening in the abdominal wall, and this opening is called a stoma. A surgical opening in the ileum or colon is called an ileostomy or a colostomy. The standard bowel diversion creates that stoma, and the location of the ostomy is going to determine the consistency of the stool, and it can range from being liquid to being formed. A loop colostomy is temporary in the transverse colon, and it's performed on an emergency basis. An end colostomy is usually done for colorectal cancer, and it is a more permanent procedure. The proximal end forms a stoma, and the distal end is removed or even sewn closed. A double barrel colostomy is where the bowel is surgically cut and both ends are brought through the abdomen. The proximal end is active and the distal end is non-functioning and it only produces mucus. Alternative approaches include the ileoanal pouch and anastomosis. This pouch is a reservoir for wastes that are eliminated from the anus, and they're used for the client that has ulcerative colitis or polyps. The Kock continent ileostomy is a small intestine forming a pouch that is emptied several times a day, and sometimes it's used to treat colitis. The Macedo-Malone antegrade continence enema, or MACE, is a procedure that's developed for a client that has neuropathic or structural abnormalities of the anus. These procedures can create psychological problems for the clients. Stomas create alterations to body images, and common problems associated with stomas include foul odors or spillage, leakage, and an inability to regulate their bowel movements. A well-placed stoma should not interfere with normal activity. Clients that have arthritis, developmental problems, or musculoskeletal problems might need some assistance with colostomy care. So the nursing process and bowel elimination. With your assessment, you do have to have your history. What is the bowel history? What are their normal patterns and habits? Some diagnostic examinations that can help with assessment would include a KUB, X-ray, endoscopy, colonoscopy, barium enema, barium swallow, an ultrasound, an MRI, a CT scan, or enteroclysis. With implementation, you also need to include health promotion. We need to try and promote normal defecation. Make sure that they're in a sitting position or an appropriate position on a bedpan and provide privacy. And some tips to help promote normal elimination. Medications can initiate and facilitate bowel elimination, but clients have to be cautioned about the use of over-the-counter medications if they're used on a continuous basis. Cathartics and laxatives are bulk-forming emollient or wetting, saline, stimulants, or lubricants, and they work on a short-term action to empty the bowel. They're often used during bowel preparations. And antidiarrheal agents can be over-the-counter, or they can be an opiate, which is by far the most effective. They must be used with caution, though, because they can be habit-forming. Enemas. Again, remember that fluid and electrolyte imbalances can occur as a result of enema administration. Potential of skin irritation and breakdown is common with enemas. The NG tube, again, is inserted through the nasopharynx into the stomach. It is a clean technique, not a sterile technique. It can be connected to suction. It's used to decompress the stomach. It's used for enteral feedings, compression, and lavage. You always assess for nose inflammation and excoriation. Assess the throat for inflammation, and you always Keiko the drainage, in addition to assessing bowel sounds. To maintain patency, you may have to irrigate the tube on occasion. With continuing and restorative bowel care, Bowel training may need to be initiated, and it is individualized. It usually requires regular routine trips, scheduled trips to the bathroom. You can utilize warm fluids by mouth, such as prune juice, etc. And you always have to take care of the skin integrity, making sure that you provide appropriate peri-care. And sometimes those barrier creams are necessary. And then, of course, you always evaluate your interventions to make sure that they're adequate and that nothing needs to be adjusted or changed.